Yeah, hi. Good afternoon, everyone. So I'm going to talk about the ACC 2021 consensus and impact, how it's impacting reduced ejection fraction. Of course, we know a lot of therapies which have made a lot of gateway into managing heart failure, especially in the diabetes conference. And if you don't talk about SGLT2, it's a big deal. But I'm going to touch upon for a change something beyond SGLT2 and how ARNI is actually having a consensus impact in managing diabetic heart failures as well. We all today I'm going to discuss about heart failure burden in India, choosing right treatment for reduced ejection fraction, the consensus statement from 2021 from ACC, which talks about initiating and optimizing guideline directed management. We'll look also at the impact of the ACC 2021 on treatment choices and heart failure with reduced ejection fraction in real world scenario, and then I'll summarize the same. So when we look at the heart failure burden in India, 1 in 3 of the patients are readmitted for heart failure. The current estimate about incidence of heart failure vary from 1.3 to 23 million, which is a big challenge. And 1/3 of the heart failure patients die within 1 year after their productive life, which is like a huge burden. And this is something which is smoldering. We are so worried about COVID. You know, the COVID pandemic had so-called with the estimates of the number of cases, 2 to 3 crores. But look at the diabetic population that we have in our country, or look at the heart failure population that we have in our country, which is actually requiring repetitive hospitalization, and it's a slow burn, and that's why probably under-evaluated, under-emphasized, and under-talked about. Hospital rehospitalization leads to, of course, higher mortality. Now, there are evidences that those who require more than one evidence will have much higher mortality cumulatively, which is 3 times one hospitalization is 3 times risk. So 1 year mortality was significantly higher if you had more than one admission compared to you had no admission at all for the heart failure. So in Indian heart failure patients, suboptimal guideline directed therapy increases the risk of all cause mortality. Patients who do not receive guideline directed management experience higher mortality as compared to those who were not on treatment. So it's all equally important to be on optimal therapy as recommended by the guidelines. So mortality rate remains high in India. You look at whether the 1 month mortality or 6 month mortality, as I mentioned, 1/3 will die in a year. So it's around amounting to 38.15%. So choosing a right treatment for heart failure with reduced ejection fraction, treatment therapies have gained in 30 years a lot of complexity. In a very busy slide, I've talked, this slide includes all the trials, all the publication about all the molecules that we've been using, studied, and emphasized upon, right from the Elite 1 and 2, with ACE getting its place, to Wellhaft, Valiant, RALS. You have Cibis 3, Carmen trial, Charm Edit, Charm Alternative, Heaven trial, and then of course the ARNIs came in with Paradigm HF on top of the so-called standard care of ACE beta blocker MRA, where the alternative arm looked at the ARNI beta blocker MRA combination. And it's a very busy slide which talks about how the therapies have changed compared to placebo background therapies. Now we have a good amount of drugs which have chosen and proven their background 30 years of over 30 years of evaluation. However, mortality despite this has remained high despite adding so many therapies in the last 30 years. We can see that ACE brought it down by 16%, beta blocker reduced by 34%. These are just relative risk reduction, not absolute. So somebody may wonder a total is more than 100 because these are just relative risk reduction on top of the baseline. And you can see the absolute numbers also mentioned below. That's like 4.5% with ACE, 5.5% with beta blockers, 11%, which was very robust with mRNA, mRNA mineral corticoid antagonist, 3% with ARB, and Shift had a relative risk reduction with ivabradine. So despite these advances, the significant morbidity mortality at 5 years remained at 50%, even in Western optimally managed and treated patients. So need for decision pathway for clinicians to treat reduced ejection fraction have been driven primarily by heart failure prevalence and escalating rapidly, having significant burden like substantial healthcare resource, morbidity and mortality of reduced ejection fraction, and quality life questionnaire. So with overwhelming evidences for the therapies, there is a need to inform clinicians about area where evidence may be new and evolving, where sufficient data may be more limited, and there are hence various gaps that need to be emphasized upon and streamlined so that the best practices could be implemented in these subgroup of patients. And that's what ACC in 2021 in their consensus decision pathways has tried to stress upon, and that's what I'm going to touch upon now. So the purpose was to implement the 2017 expert consensus decision pathway, which was developed in 2017 from the emerging study, and to provide practical guidance for managing these patients with an objective to encourage clinician to question what are the important factors that will determine what therapy you will choose, and to provide a unified articulation of practice guidelines so that the appropriate use is established, and then you streamline the care of realize best possible treatment in heart failure. So the first thing that they touched upon is when to initiate and how to optimize. In that, the early implementation of the therapy is something that has been stressed upon, because there are a lot of patients who are not actually reaching the optimal therapy, because we go a lot of times initiate one therapy at a time, and then the patient is lost to follow up, or when he comes, then we just up titrate the first therapy. So what they have stressed upon as a consensus recommendation is that we should initiate either or RAS inhibitor or beta blocker at the time if you're worried about the two. In some cases, actually, you can start both. So this is something that the combinations in our part of the world allow us to do. We usually end up putting them on a combination of beta blocker, ACE or ARB, or sometimes giving ARNI separately along with the beta blocker. So both have been up, then they should be up titrated every 2 weeks. Now that's a problem in our country, because you can't call them very frequently at 2 weeks with the kind of burden and the kind of disparity that exists between the doctors, number of doctors and the number of patients, especially in the government setup. If we were to call every patient 2 weeks at the institute, then probably our OPD numbers will never end. We'll be having 24 hours kind of a OPD, and still be there'll be long queues. So what we intend to do is probably start with a combination and then step it up rapidly as and when the follow-up is there, escalate them and ask them for a home blood pressure monitoring, though that's not part of the ACC consensus statement, but that's the Indianization of the guideline. So algorithms have been that we all know stage C, you start with either ARNI, ACE or ARB, and then add an evidence-based beta blocker along with a diuretic agent. And if the patient's EGFR is more than 30, and creatinine less than 2.5 in males or less than 2 in females with no potassium, you can add an aldosterone antagonist as well. In patients who meet the EGFR criteria in class 2, you can still add now the other favorite therapy, which is SGLT2 therapy, which is post DAPA HF and post Emperor reduce, is so robust that you even need not look whether they are diabetic or not. For patients with persistent volume overload, of course, diuretics can play the role, but then of course remember that you've exhausted SGLT2 and then added this. And in patients with persistent or who are black, symptomatic, or where there is contraindication of getting an ACE, which is commonly what we use in patients with high creatinine or renal failure patients, where you can't use ACE, ARB or ARNI because of the EGFR being very low. Good choice and alternative, or in symptomatic blacks, would be in class 3-4 patients to add hydralazine with isosorbide dinitrate. In patients with high heart rate more than 70, and if they are already on fully tolerated beta blockers, class 2 and 3 patients, we can add ivabradine. So key changes in the treatment now have been that ARNI is preferred as the first line RAS inhibitor in patients with heart failure with reduced ejection fraction. Those in whom ARNI administration is not possible, only in them that ACE and ARB is being talked about. So SGLT2 are added, of course, as a part of the therapy in patients with chronic heart failure, reduced ejection fraction, already on beta blockers, ARNI and aldosterone antagonist if not contraindicated. So what are the evidences? Let me talk about why did ACC talk about this. The evidences we know have been derived from Paradigm HF, and there are data from which I talked about DAPA HF and Emperor Reduce. And the recommendation for optimization from the consensus statement have been to achieve maximal benefit of guideline directed therapies. Should be initiated and titrated to maximally tolerated dose, and the target dose are associated with best outcome, and titration should cover even if the patients appear stable or their symptoms and or the ejection fraction improve. So don't stop ARNI, don't stop SGLT2 if their so-called symptoms are now class 1 and or their ejection fractions have started improving, because once you withdraw them, again, the worst thing is there. So the guidelines do talk about continuing the therapy even if the improvements are there, because withdrawal it can be worrisome and you may not get the same benefits once you reinitiate the therapy. Beta blocker dosage should be adjusted every 2 weeks in patients with no evidence of decompensation. Initiation of ARNI and dosing, if previously on ACE, you'll have to stop at 36 hours before. If the dose is to be equivalently adjusted for presence of valsartan or enalapril with 50 md BD, and then you go up to 100 BD for the corresponding dose of less than 10 or more than 10 of enalapril, or less than 10 or more than 160 of valsartan. And in 2 weeks, you'll try to reach the maximal dose of 200 BD. And you have to monitor, of course, the blood pressure, renal function, and electrolytes. Of course, the indications remain as of now. Anybody whose ejection fraction is less than 40, for the preserved ejection fraction or mixed range, mid-range ejection fraction, the data is not so robust and so potent, which we know from the other trials, but which is beyond my talk today. The class 2 to 4 all are included, administered in conjunction with the standard care of therapy, replacing ACE or ARNI. And ACE and ARNI should be considered only if the ARNIs are contraindicated, not tolerated, or not available, which is very, very rare. So once the therapy is started on ACRB, again, you'll have to do the same 2-weekly monitoring. For beta blockers, bisoprolol is a therapy that I usually prefer because it's easy to titrate, because bisoprolol 1.25 going to 10 is much easier. Carvedilol 3.125, usually most of the patients will be stuck on that dose for lifelong, because otherwise recommended dose is 25 BD, and most of the data is on that dose, which people don't achieve. Once you have started with the dose, metoprolol is preferred when there are patients of arrhythmia. Of course, there are no add-on comparison between the three, except COMET trial, which compared carvedilol with metoprolol and found some superiority. Again, it's got some controversy. If we have time, we can discuss that as well in discussion. And increasing dose of beta blocker, again, every 2 weeks, you can monitor heart rate, blood pressure, and congestion. And with no evidence of decompensated patients, it's a therapy that must be initiated. SGLT2, of course, I think I need not be talking in such a learned forum about it, which you all are much more aware than me. EGFR cutoffs for DAPA was 30, for EMPA was 20. In the two important trials, the DAPA-HF and EMPEROR reduced. And this is when ACE, ARB, or ARNI plus beta blocker were already used. This was the standard care. On top of that, it was started. And then in conjunction of that, we need to optimize. Diuretic should be added for symptom congestion, because barring MRA, no other diuretic group is known to reduce mortality in heart failure. If doses is excess of 80 milligrams of furosemide are needed, then you'll have to either different loop diuretic or a thiazide addition has to be considered. And if heart rate is more than 70, as I said, ivabradine can be added. So in general, to speak, medication adherence has to be assessed regularly. Interaction help with the adherence include patient education, medication management. A lot of times we see similar sounding drugs being replaced, changed. Simple example I would give: metoprolol succinate versus metoprolol tartrate. Now, most of the data exists for metoprolol succinate. Metoprolol tartrate has got pretty bad reputation as far as at least heart failure is concerned, because that's where it lost out in COMET trial with carvedilol. So choosing the drug, not just prescribing the brand, but also what drug and what salt the patient is taking, is also imperative for the physician to be dealing with the patients, to educate them, to stick to the kind of drugs that they should be on. Goals of care should be addressed during the course of illness, and team-based is critical in optimizing the guideline-based therapies. Case discussions, let me just, for an example, give you a case: 60-year-old female teacher who's already on ASMR and beta blocker with EF of 30, NT-proBNP of 250, blood pressure 120, EGFR of 60. I would usually switch the patient to ARNI. The reason being that it's now recommended with ACC 2021 as the first recommended line of therapy. Changing over has also come now in the European guidelines that patients who are still unstable on ACRB can be switched over. Of course, not class 1, but based on evidence, the ARNI has expanded from the 2017 guideline also because of superior efficacy and de novo therapy, which is in patients who are naive, and rapid improvement and reverse remodeling, which is happening irrespective of the background ACRB. Paradigm HF and Prove HF trial were two important trials. Paradigm HF clearly showed 20% reduction in primary outcome of CV death hospitalization as compared to ACE, which was enalapril, and Prove HF, which showed in reverse remodeling and improvement in NT-proBNP at 12 months with this combination. So results from Prove HF further substantiated by Evaluate HF, which shows improvement in echocardiographic parameters as early as 12 weeks, which we very commonly see in our practice. You look at their size, very bad LVs, with regurgitation. First thing that will happen, that ejection fraction doesn't improve. First thing, the regurgitation starts decreasing. Then the LV size starts improving. And it's only later on that the EF starts improving. So the early phase, you will very often find improving as soon as 3 weeks or 3 months. So superior outcomes were also seen in Pioneer HF, where initiating ARNI with and decompensated was feasible and superior to enalapril. So in acute heart failure also now there is emerging data. Transition study where about half of the patients would achieve the target dose within 10 weeks, so at the time of discharge. So the fear of up titration not being possible is no more true. In patients with newly diagnosed heart failure, inpatient initiation of ARNI has greater reduction in the peptide concentration comparable to safety profile and improving in the clinical outcome in Pioneer HF. So we now know that all reduction in all-cause mortality when you combine ARNI, beta blocker, and MRA is by 63%. When you compare this, when you replace this ARNI with an ACE or an ARB, the difference starts going down. And when you're looking just an ARB and a beta blocker, it's 53%. So it's absolute that there's 10% difference that exists when you're choosing ARNI instead of ACE, ARNI being replaced by ACE or an ARB. ACE, for that matter, with MRA only 43%. So either of the therapies is not sufficient. And because of such totality of data, direct to ARNI approach is what is recommended. SGLT2, which have shown efficacy in both diabetes and without diabetes, should be added on therapy irrespective of diabetes, as was touched upon in various other talks. SGLT2 are added as a part of therapy in reduced ejection fraction, already receiving the 3 class of the therapies. And this as an add-on have shown improvement in outcomes with patient-reported outcomes in both DAPA-HF and AMPERE-reduced trials. DAPA-HF demonstrated reduction in worsening of heart failure and death for CV cause, and AMPERE-reduced demonstrated composite endpoint reduction, and hence make it as a core therapy in clinical trial. So to summarize, for patients that I discussed upon, switching to ARNI in place of ACE ARB is something that is recommended. Sacubitril valsartan is essential for heart failure with reduced ejection fraction therapy by reducing the risk of CV death, hospitalization, and cardiac function improvement. The consensus also recommends use of ARNI, evidence-based beta blocker, aldosterone antagonists, SGLT2 inhibitors as first-line medication, and novel therapy like SGLT2 is administered in conjunction with a background of heart failure reduction. So do you agree with this consensus is something that I will open to the forum? We can all discuss whether you believe that this is true and what would you be choosing. I mean, I not only de novo patient, I would of course go ahead with an ARNI. I would discuss with your elite panel that whether you would cost will still be a consideration and would make you choose ACE or ARNI. And will you switch from reduced ejection fraction patients already on ACE ARNI to ACE or ARB to ARNI? What is your GDMT for these patients with diabetes? For me, it's of course ARNI, beta blocker, SGLT2, and MRA. That's what I use. But of course, the other 2 options are something that one can easily contemplate and argue for, just for one reason, that's the cost. These are the package insert, and these are my disclosures. Thank you very much. Thank you for patient hearing. I'll stop my slides and we can have discussion. Thank you. Over to Chair.